the precursor. Right. Thank you all very much. Welcome to our board meeting. I'm Angela Greatley, board chair, and I'm about to begin the meeting with apologies. And the only apology I have is Charlie Sheldon, our chief nurse, Jane Walbridge, who's our trust secretary, and I'm announcing that, Jane, for people who are watching so that they'll know your place in the work that we're doing this morning. Do you have any other apologies?
No, just Charlie Sheldon. Thank you.
Thank you very much. We have today, first on our agenda, we have a written question from a member of the public. I'm going to pass over to James Benson, our interim CEO. Welcome this morning, James. And you're going to deal with the question, I believe.
Thank you, Chair. Yes, the question in advance was around a North West London CCG board meeting that was held on the 21st of April, in which there was a record of the trust being commissioned for a £5 million contract for intermediate care beds. We have actually written to the CCG regarding this point. Their paper is inconsistent and not clear. It makes reference to CLCH and also CNWL, our partners in North West London. My feeling is that the actual paper is entirely reflected of Central and North West London Foundation Trust, and we've asked that their papers be corrected to reflect that. There is a secondary question, which is around whether or not, because we are part of our North West London integrated care system, it would curtail any further work or contracts outside of that ICS. The board has discussed previously, and I would continue to feel that because we are a strong partner in the four different integrated care systems in which we work, that we would continue to work in those areas. We would continue to work with partners to develop services that meet the needs of our residents, and would be looking to improve the way we deliver those services, and potentially that may result in additional services in those areas. And we have seen that over the last year with new services as part of the Ageing Well programme.
Thank you, James. So just to summarise, it's not a let or hindrance to our being involved in other ICSs, and we intend to continue in the four where we work. We're not looking for others, though. I think would be fair, and we don't have an extra contract from North West London CCG. Okay, thank you very much. Now I'll move then to 1.3 of our agenda, and that's to ask if there are any interests relevant to this agenda that need to be declared for this meeting that haven't been declared elsewhere in advance. I'm looking round, I don't see any. Thank you very much, colleagues. I'm going to move to matters arising, to the minutes. And what I'll do is I will call the red number on the bottom right-hand corner, and I'll go fairly quickly first for corrections or amendments to the minutes. So 3, 4, 5, 6, 7 and 8. No one's raised any issues. May I sign them as a correct record? Somebody can nod helpfully, or yes, lovely nods around the screen. And I'm now going to matters arising in the action log. I will take the action log first, if I may. That's on red page number 9. So the first item, which was 0522, organisational objectives. We have a paper later in our papers today just to agree to the publication, or to note the publication. So with your agreement, I'll regard that matter as closed and have it removed from the action log. 0622 is about the methodology and the metrics for PRISM, which is related to counting issues related to mortality. I'm going to go to our medical director, Dr. Jo Medhurst, to ask if she has any update on that. Jo?
Yeah, first of all, apologies to the board. I said I would do a written briefing, and then there was some sickness in the team, and I've just, honestly, it was an oversight on my part, so apologies to the board first of all. What this relates to is the KPI that's now come off the board KPI. Do you remember we changed this for the sort of the beginning of April, and it's actually around the sort of the naming of the KPI. What the KPI measures is the triage process for all death in the trust. So when we have a death in the trust, there's a very sort of simple, I think it's about 8 questions people go through saying, is this of concern, basically. If it's of concern, it has a full-blown PRISM, which is a research tool for people in the audience. It runs to 26 pages. What this metric measures is the triage tool. So we know that all deaths are scrutinised by our services. It's normally a band 6, band 7 sister, or sometimes it's the DDNT. The issue with the metric that was picked up at Finance Committee was in the handover between new DDNT roles, there was just a little bit of miscommunication in one of the divisions, and so those were not being done and they weren't being counted. We've retrospectively looked at it, that's all now back on track, but the PRISM, which are the deep dive for deaths that have concerns to them, are 100%. So we did fall off trajectory for the measure, which wasn't PRISMs. That's now been remediated and back up through the Resusc Mortality Committee. But the PRISMs was 100%, is 100%, and has maintained 100% from a number of years now. Is that helpful, Angela?
Just do that. Jo, that's really, really helpful. My colleagues, and that it was raised at Finance, and a couple of us are members of Finance. Also our colleague Jitesh, who's chair of Finance. Unfortunately, his camera can't be on today, but I'm just looking to see whether people are now confident and happy that that is the answer that answers our query, and we can now close that and take it off the log. I think our worry was whether the PRISM had all happened, and
I can assure the board it has. And again, I've copied Malcolm in as Acting Director of Finance, so he can see the audit trail, and we've got a written report that came in from the chair of the committee, just to finish off the assurance loop if it was ever reviewed.
Perfect. Thank you very much, Jo. So with your agreement, colleagues, I'll take that one off the action log as well, and that clears the action log. Can I just ask people, do they have any other matters arising from those minutes that are not elsewhere dealt with on the agenda? Don't see any hands up. So thank you very much. That concludes minutes and matters arising. We'll now go to the next report, which is my report as chair. I'm going to assume that people have read it. I'm very happy to take any questions or comments. I have one brief addition, which I thought would be interesting to colleagues. On Monday of this week, no, it might have been Tuesday of this week, I attended what is called the Anchor Institutions Network, which by its name, we all know we aspire to be an effective anchor institution in our communities. Absolutely fascinating. And I will send a note round, but it seemed to me that colleagues would like to know that much of our work, both as we're beginning to think about social value and the contribution of the Academy particularly to creating opportunities for local communities to work in the health, has been widely recognised. So it was good to be able to be at the meeting and to hear more information, but also to note that our own work had been recognised, and I will continue to participate in that group. So other than that, the report's presented. Anything anyone wants to ask me about? No? Okay, thank you very much. It's there for the record, and thank you, colleagues. I'll now move to item 1.7, and that is our interim CEO's report. James.
Thank you, Chair. I'm sure colleagues have read my report, there are a few things that I wanted to attend to. The first is at 2.1, and I'm really pleased to see that our inner London boroughs have again retained their gold status for UNICEF, for the Baby Friendly Initiative. I think we would all recognise the importance of this work and why this is important for the health of our future generation. There are two notes around staffing changes in my report. The first is around the appointment of Martin Jones to be the FTSE Guardian of the Trust, which is important in terms of ensuring that our staff have a voice to raise concerns with us as a board. And the second is at 2.5, and it is with deep sadness personally, but pleasure in terms of her future career, that we accepted the resignation of Dr. Joanne Medhurst, who has been our medical director for a number of years. And colleagues, this by virtue of the fact that Joanne has some annual leave that is owing to her, given the amount of work that she has done. This will actually be Joanne's last board meeting. So Chair, I would hand back to you just for our comments.
Yes, Joe, can we thank you? Thank you just massively for everything that you've done. And I think anyone who reflects on the 2 years plus of COVID will know that the enormous contribution you were already making, you redoubled. And you often made me think, this is giving my age, of that old Beatles song, 8 days a week, because you certainly seem to be working more than 7. And with colleagues made a huge contribution. I like to say this, but I'm not sure I'm convinced. Our loss is someone else's gain, but I wish, you know, they hadn't gained you in a way. And I know that you're going to be a very great ICS medical director. And I'm looking around colleagues, people are smiling and nodding, and people want to record their thanks, I'm sure. We'll probably get a more informal opportunity, and some are using the technology to say thank you, Joan. I'm sure we'll all get another opportunity to say this more informally, but let's record our thanks to you. Do you want to say anything, Joe?
Just thank you, everybody. It's been a privilege to be at CLCH, and I'm very proud of the 10 years I've been here, the progress the Trust has made, and how we work together as a statutory board. Thank you to all of you for supporting me to be able to deliver across COVID and being part of this terrific team, both executive team and board team. Thank you.
Thanks very much. The other thing I did want to just remark is that the appointment of the new FTSE is incredibly important. And just to remind people who are on the call that Carol Cole is our non-executive director who leads on these matters. So something you'll be working on to help induct the new FTSE, I'm sure, Carol.
Thank you, Angela. He and I have already met and had a very constructive hours conversation. So looking forward to working with Martin going forwards.
Lovely. Any other questions or comments to James?
So
Jane Slatter.
It's more of a comment really, Chair. It's just to say, pleased to see that we have Martin as the new FTSE, and I know Carol will be picking up the baton and meeting. But can we also sort of just think about making sure that we bring Martin to board at some point, because of the way things have worked out, we've not had a session with the FTSE for a while, so I think that would be a good idea. Thank you.
I think that's an excellent suggestion, and we should of course just note our thanks to Liz Lubbock, who took us very well, if you like, into the area of becoming more competent and confident about our FTSE work. So back to you, James.
Thank you. So in terms of an interim arrangement, the paper identifies that Dr. Nicola Kemp, our Deputy Medical Director, will be acting as Medical Director until such time as we appoint. And therefore I move to the absolute appointment that is in the paper, which is we have offered the post of Director of Finance and Corporate Services to Jenny Greenshields, and she will be starting with us at the end of August this year. And I've noted my thanks not only to Jitesh, but other supporters who went through the interview process. And I feel that was quite an in-depth process that we had a number of stakeholder panels. So my genuine thanks to people. My report also identifies the amazing work done with partners in Northwest London. at a job fair at Lord's. Our chief nurse was a strong supporter of that in his leadership role, and North West London recruited over 600 people at that one event for all partners. I think that's really quite amazing level of recruitment. And then I couldn't help but note at 3.1 the fact that the Health and Care Act 2022 has now passed into law, and therefore we are starting our journey as a National Health Service into the creation of integrated care systems, boards, partnerships, and a variety of other different arrangements which the organisation has been working on and with partners for over the last few years, and we will have a number of those papers today and moving forward. Thank you.
Okay, any further questions or comments that you wish to address to the interim CEO? I'm not seeing anything. Jane, I was just about to say, I think that's a new hand, Jane.
The new hand, not an old one. Just to say how heartened I was by those 60 offers made at that London recruitment fair in North West London. And, you know, it'd be great if we could seek further opportunities, given, you know, in our other sort of ICS patches as to whether that's something we can explore, because quite clearly, you know, we're stronger together, as it were, when we work on resourcing, given, you know, some of the scarcities we have in some of our specialist roles and some of those things. So absolutely super to see that there. Thank you.
So I would concur, Jane. You know, I think not only has the system managed to get 600, we've got 60 into the trust, and I will be discussing that with Charlie when he returns from leave about how we might manage that with our other systems.
Lovely, good point, and well made. No more questions or comments. Let's then move on to the next agenda item at 2.1, page 18, and this is the system development update. James, shall I move straight to Anne Waitley to present this?
That would be helpful, thank you.
Anne.
Thank you, Chair. So James has already said it, the health and care bill that we've been talking about for some considerable time has now become an act and has received royal assent. So from the 1st of July, the statutory functions that currently reside within the CCGs will transfer to the new integrated care boards, and I think it's fair to say that 2022-23 will be a transitional year, and I think much will continue as is as these new integrated care boards come in. So, for example, in terms of our current contracts and so on. I think the desire, the intention of the integrated care boards is to be different from the current CCGs, and to that end, they will all have partner members from the provider community, as well as other partners on the board. So it's not just about commissioning, it's actually about systems, the whole system, population health, targeting inequalities in our systems, and really their success will be in the difference they make, I think. And it's really important, therefore, for us as a provider who provides across 4 integrated care systems, that we continue to engage fully with those developments in each area. The paper outlines the latest, particularly appointments and developments in relation to the integrated care boards. They will become a reality. I won't go into detail. I'll assume happy to take any questions. Just a couple of points to highlight. Within Herts and West Essex, it's just important to note that within the place that we work in, South and West Herts Health and Care Partnership, our CEO, James Benson, has become the deputy chair of the HCP. We are a key partner as the main provider of community services in that patch, and we work very closely, particularly with the acute trust in that patch, West Herts Trust. Within the work stream.
I've lost sound, Anne. I don't know if others did.
I'm in the office. Can you hear me now? Yep. So within NCL, our Director of Operations in Barnet, Kay Isaac, is leading one of the work streams under the Community Services Review that I reference. And again, we're very involved in the other work streams. In North West London, James is the SRO for the local care programme, which is really looking at the whole breadth of services outside hospital, and for which the community provider collaborative is acting as the delivery arm for those areas where are under the purview of the community NHS provider trusts. And finally, with South West London, we are working very closely with the Chief Executive of Hounslow and Richmond Community Trust to really identify how we can make sure that the community place on the Integrated Care Board really brings all the expertise around community services that sits within that system. I identify in the paper a number of considerations that we will want to work through as a board as the systems continue to develop, and we will bring those for discussion over the coming months. I had a couple of questions around the costs of transition and implementation of the new statutory arrangements. At ICS level, I'm unable to say how much. The question was how much. What are the indicative costs of the transition and implementation of this new system? We don't have that information at ICS level, but I think it's fair to say that much of the transition work has been led from within the current leadership, both of the CCGs and of the providers in that system. But I couldn't tell you how much that would be. And second question about how much the partnership working has cost us as an organisation. If you remember 2 years ago, the post of Director of Partnerships and Integration was created to enhance our capacity to work within those systems. So I think that was probably a key cost. But I think it's important to note that as a leadership team within any of the providers in the system, working as a partner, working with other organisations, working with our communities is all part of our leadership roles. And I think that's really important going forward. It's something that we've always done as an organisation. We've always worked with other partners within each of the places that we work. And as the emphasis is on joining up services for bettering the experience of patients, I think it's important that that's seen as our ethos, and I know the board understand and support that. Thank you, Chair.
You're happy to take questions, Anne, and just to say that the questions notified in advance are the ones that Anne's addressed, and then we'll open up to other questions and comments. So Clive Sparrow.
Thanks, Chair. And I just wondered if I could follow up on your answer to those questions. This is a very major change within the NHS arrangements, and I just feel that I understand the points you're making, and I understand the benefits that are expected to come. I just feel that we should at least have an understanding of the broad order of costs of implementation and engagement. You know, this is not a free good. So I just feel I would like to understand a little bit more about the costs of the change.
Could I clarify, Clive, is that our own costs? Because much of the ICS costs are, if you like, encapsulated in the changes from the CCGs and all of the staff moving over. And I don't think we'll see that for some time here. But if it's about our costs, I don't know whether Anne wants to consider whether we could be clearer about that. But certainly we've always worked with other partners in the way that perhaps some other institutions, thinking more about the large acute hospitals, have done less of that in the past. But I think we might be closer to our own costs. Any comment, Anne?
Yes, I mean, we can certainly. Certainly, Clive, was perhaps something that we could pick up and think about outside. I think it's fair to say that we've not brought in enormous numbers of extra capacity to do some of these things, but so in one sense we can identify that. I suppose some of it is absorbed within everybody's roles, so that would be harder, I think, to quantify, but it's certainly something we can take away and have a think about.
Okay,
I would appreciate that. Thank you, Anne.
Yeah, Clive, let's do that.
Jane Slatter.
Just so I don't think it's something we can do now, but in support of Clive's comment, I think it would be useful for us. And I know much of the work has been sort of integrated into the executive team, and it may be harder the further you get down in the organisation to quantify the cost. But I think we could probably, take on a fairly scoped, focused exercise that looks at, particularly, we know around our leadership team and some of the effort and time we've expended, we know how much that is. So I think it'd be quite useful, good discipline for us to be able to look at that and just weigh that up in the future and see how that, compares to what we'd expected it might be, and the versus the value equation as we go forward. So I think it's a good idea. Thank you.
Can we take James next and then Jo? I think that was the order the hands went up.
I think it was the other way around, Chair, so I'll defer to Jo first.
Thanks, James. So I'm going to pick up on one of Jane's points. So I think we can look at cost, but of course the direction of the NHS is to look at value. Value is cost, experience and outcome.
Yeah.
And I think the question should be, are the changes delivering value for the organisation and value for the patients that we serve? Purely looking at cost, I think, is a third of that agenda, if that. And I suppose the other bit, Clive, that I would challenge it is, well, it may be more cost to do the integration, but what have we stopped doing in the commissioning agenda? So we, bid writers, the cost of contracting, doing the bids, that is a significant cost. So if you look at the balancing, the differential cost, or the delta, I think people call it, if you look at the delta, what is that? So looking at the crude cost, I'm not sure what we're going to do with that crude cost unless we look at those other factors and we go it through a value lens, which is how the health service are describing these sorts of use of resources. So it feels, I don't disagree with asking the question, but I think we've got to see it in a broader context than just money, would be my challenge back, Clive.
Chair.
Yeah, I'm not in the school of knowing
Clive,
the cost of everything and the value. Sorry.
Yeah.
So I was only just responding to Jo. I'd like to think I'm not in that group that knows the cost of everything and the value of nothing. I do think that it would still be useful, and I'm very happy to offline. I think we said, without creating an industry, just to get an order of magnitude of what we're talking about here, and very happy to consider it along with outcomes and value, as you suggest. I agree with you, Jo.
James?
So yes, so I'm happy to take an action. The executive team will debate this as to how we might qualify and quantify this, and to what ends and for what purpose. But I was going to go to the same point that Joanne raised, which around the value statement, and has it improved the way we deliver care for our residents?
Okay, I can't wait to not have to do all of that contract negotiation with very, very small organisations. That takes a lot of time. So it will be an interesting proposition, and one, Clive, that we probably ought to do as the year progresses and we begin to see how it falls out. Other questions or comments to Anne? If none, Anne, thanks for your report. I think we were to receive that for information, so we don't need to make any decisions at this point. I suspect it will become a very large part of our agenda. So back to Clive's point, we'll certainly be spending some of our time on it as matters progress. I'm sure that's right. Okay, then, if we've noted that report, can we move to 3.1, the quality report? And I'm going to Billy Hasafani to present that.
Thank you very much, Chair. I'd like to present the quality report to the board for discussion. I'd like to note the great work that we've been achieved in the last year in relation, considering the amount of work and the pressures the teams were under with the pandemic. We've managed to achieve a majority of our KPIs, which are aligned to a quality strategy. And for those KPIs we didn't quite deliver on, those are our stretch target KPIs where we're aiming for 0. So our pressure answers, category 2 pressure answers, and I think, and our falls prepared in embedded areas. The report outlines a lot of work we're doing with those teams, targeted work to ensure that we deliver marked improvements in those areas. But I think comparing like-for-like data from last year, we have seen marked improvement in the numbers, although we haven't quite achieved the stretch target of 0. And there were a couple of questions, if I may jump into the question that came through. The initial question, the first question was around our quality approaches and our quality KPIs, whether there's a way of not over-engineering it. I had a moment of reflection about this yesterday, and I had a discussion with others in the team just to explore what the fine balance is in terms of delivery of KPIs and our overall quality agenda. Our quality strategy is quite clear in terms of how we try and ensure there's a balance between in our quality assurance process, our quality planning, and our quality improvement. What we're trying to do is we're on a journey of improvement where we're doing assurance, and also planning, and then also ensure the teams are ready for the improvement part, but investing in the improvement team to ensure that we deliver that part as well. So I think it's a fine balance, and we're on a journey to that. The KPIs we'll see in a performance report later on, where we're using SPC charts, is part of that journey, where we really trying to delve down into minutiae of the issues that are causing the fluctuation in performance. And I think once we get through to that point where we know teams are ready for improvement, we're going to support them on that journey to improvement. Then the next point, another question was around the annual security report and the full analysis of incidents of aggression towards healthcare staff. That report is coming to the board in July, Chair. So hopefully we'll have a full detailed report in that July meeting where we can outline what we've done over the last year. But just a point of note is that our work to ensure that we follow up all incidents of aggression towards the staff as we've now got more data, and we can now evidence more targeted support to those teams and sanctions where required to manage that behaviour. But there'll be more detail to the July report. But happy to.
I wonder whether, for the purposes of avoiding kind of moving between two reports and not being quite clear, I'm going to ask my colleague Carol Cole if she will put the report from the committee, not the minutes, the report from the committee on the table as well, because it covers some of the same points. And then I'll take questions to both Billy and Carol. Is that okay, Carol?
Thank you, Chair. Very happy. And in fact, those eagle-eyed colleagues will have spotted we've actually put the Quality Committee report alongside the quarterly quality report, so it's coming as a kind of integrated package rather than historically as we have done, which was to have from our chief nurse and today Billy talking about the quarterly quality report and then having the quality committee at the back end. So we're keeping them together. So thank you. Let me just say very briefly, I'm going to take the 3.1.1 as read, but Chair, if I could just draw colleagues' attention just to 2 or 3 points in it. Firstly, to echo Billy's comments about the quality of work which has been done by colleagues in the quality and clinical kind of workforce during COVID, because our quality committee was looking at not just the last quarter, but the whole of the last financial year. And I think, yes, we will never rest on our laurels, but I think we just need to acknowledge the hard work that has been done as evidenced in the KPIs that we were measuring for last year. So with respect to the report, just to echo our CEO's observations around the UNICEF Baby Friendly initiative, our patient story, our service story this time was around breastfeeding. So it was very timely in light of that gold status accreditation. But what was particularly interesting, and our outgoing medical director will, I hope, welcome this, was in addition to hearing about an individual patient's experience, what we also heard was the value of the data analysis, which was supported by the local authority. So teamwork, if you like, at an integrated ICS level almost. But the data analysis which was done using local population health data, which prompted a change in targeting where in the borough breastfeeding support was being provided. So it was being provided to those who would benefit from it most, which I think is absolutely fantastic and a perfect example of using data and insight to lead to an improvement in service provision. So I think that was absolutely super. Just wanted to say this is just the kind of thing we as a board really want to be behind. So fantastic. At 2.2 in my report, you'll just see a list of the wide range of initiatives and campaigns, etc. underway. Not going to dwell on those, but to echo the fact that there's a lot happening and a lot of it's happening really well. We did discuss the outcome of a whistleblowing investigation in Barnet, and we received an update from the chief nurse on Jade. And indeed, since the committee has met, we have received a further update from the chief nurse indicating that the trajectory, the improved trajectory, is being maintained. So, Chair, that's enough from me on that. I will pause, and between Billy and me, we can take questions from colleagues if there are any. Thank you.
Thanks very much. Thanks both. Questions, comments? I've got James' hand up. Do you want to make a point and then I'll call Clive in?
It was just regarding the question in advance. Billy and I actually discussed this, an opportunity to discuss how we assure ourselves that we don't over-engineer our processes as an organisation. And what we did discuss was that we feel that the approach to managing quality, our processes probably are gold plate, i.e. silver with gold over it, which is not too gold and not too silver. And that's important because what we felt was that we have both a responsibility as a board to assure ourselves that our processes are not disproportionate and that we deliver on quality. And I think, you know, the fact that we have stretch targets, I think is really quite amazing. And even though we haven't met those targets for pressure areas, that is truly a level of care that I think we could all be particularly proud of. But the other thing that we discussed was that we have a responsibility in terms of developing our colleagues, that we can't ensure process is only at the level of the executive team, and therefore our processes are educative in and of themselves so that we can teach our team leaders, our service leaders, our CBU managers, our director of nursing and therapy, how to lead and be leaders for the future.
Very helpful comments. Clive, did you want to come in?
Please, yeah. I just picking up on James and Billy's point. I know we have a very proud record on quality. My question wasn't intended to be a criticism. It was genuinely how we ensure that we have incentives in there to be lean. And so I understand what you're saying there, James. I wasn't sure that answered the question how we ensure that we don't over-engineer. And I wonder whether, Carol, from the perspective of your scrutiny at the Quality Committee, whether there's anything that you would point to that just ensures that we don't gold plate, as simple as that, really, because I'm not hearing the practical ways in which we ensure that doesn't happen, because it's a risk in many organisations that focus on quality.
Clive, thank you. It's a challenging question, but thank you for raising it. It's a tricky one because we're kind of damned if we do and damned if we don't. If we, for whatever reason, choose to have fewer KPIs or set ourselves lower targets. I think we're not aspiring to the level of quality of care that we would want to. So my own sense is that we don't over-engineer it. We've been using SPC, statistical process control, to give us intelligence to make sure that we can use the data that we're getting from identifying our KPIs and monitoring our performance. And I'm very happy to kind of chat further offline, Clive, around you know, between us and perhaps with Billy and with Charlie when he's back, a little bit more around this. But my sense is that we don't gold plate. Arguably, we have, in a sense, paradoxically gone the extra mile. So, for example, there is no requirement, and correct me, Billy, if I'm wrong, for us to look at category 2 pressure ulcers, but we chose to do that in order to begin to identify early on and not wait till a category 3 or 4 emerges when it's too late to intervene in the process. So that would be an example of, if you like, arguably over-engineering it, but I would say actually working smart rather than working hard. Another example would be that there's no requirement now for us to have our quality account audited. We have chosen to do that again. So I think where there's some discretionary choice, we've always opted to actually be a little bit tougher on ourselves for the right reasons. So I'm not sure if I'm kind of answering your question, Clive, but and I'll look to Jane as the other member of the committee if she wants to come in and supplement what I'm saying. My own sense is that we don't gold plate, but we have, if you like, aspirational silver/gold standards, which manifest themselves in our KPIs and how the committee seeks assurance. Does that kind of answer your question? And if not, I'll pass to Jane to give the right answer.
I'm happy to bring Jane in, and then I'm going to bring Billy in, who might give another further part of the right answer. Jane Slatter.
Well, it's just to back up what Carol said, really. I mean, you know, we've had those conversations at committee over the years, and we looked at it strategically, and we always, I think we have challenged ourselves to say, you know, okay, we don't need to do this, as we talked about with category 2 on pressure ulcers and those types of issues. But, you know, is it the right thing to do? And how do we balance the level in terms of, you know, what's sort of going over the top and what isn't? And is it going to, are we smarter working in the sense that, is it going to prevent us doing a whole lot of other activity if we don't put this in place? And I've been party to lots of those conversations, and it always comes to the table. It is fully discussed between the executives and the NEDs at the committee about what's the best strategic approach we can take, and the emphasis being on strategic, in the sense that we've been on quite a long, you know, term journey with our quality improvement. And I feel now we're getting to the point where we're not looking at things for the wrong reason, because we've got that statistical process control in place, and we can see things across the broad spectrum in terms of if something's going outside a control zone or there's a regular theme, we can pick it up. And we're having a much more intelligent and strategic conversation than we might have done, say, when I joined back in 2018. But I'd say we always challenge ourselves about, are we overdoing this, or and you know, are we you know, making it an industry in itself, but the outcome is for the patient, but also for efficiency and effectiveness at the same time. Thank you.
Billy.
Thank you, Chair. I completely agree with both Jane and Carol, and I think, Clive, thank you for your question. I think what's important is that going back at our quality strategy, our KPIs evolve every year for the duration of the strategy, which is a 5-year strategy. So we don't keep asking the same questions. We ask slightly different questions in terms of where we are and how we've improved in the previous year. So that keeps us on our toes. And I think the quality committee itself is it's a good forum, but there's a good challenge in terms of what are we monitoring and is it adding value, what we're monitoring. For instance, I'll give an example of our better scorecard. So that's not a performance scorecard, that's a quality improvement scorecard. So what it says is, have a look. Is there any reds that you want to be curious about? Let's have a look to see whether the teams need support. So I think it's about how then do we ensure that we're having the right discussions with the data, not necessarily always seeking performance, but more about going to look for opportunities to improve. And I think that's what the committee does, and I think that's why we're trying to find the right balance to show in this report. But I think it's an ongoing process where we need to just keep going back and reviewing, make sure that we've got the right balance, because it is a fine balance we need to balance. Thank you. Hopefully that answers that. Thank you.
Thanks for, I mean, a really interesting debate, I think, about how we challenge ourselves to ensure that our processes, which in the end all turn to the quality of the experience for patients, don't they? Patients and their families, that they serve that purpose. So I think that was a really helpful debate. We'll keep coming back to it. Thank you, Clive, for raising it. Are there other questions or comments on first the Q4 report and second the report from committee? I don't see any, so thank you for those reports, and we will note that they have been presented. I'll move now to 3.2, which is the Integrated Finance and Performance Report, and I'm going to welcome Malcolm Hall, who will be doing this, I think, for the first time to the full board. Malcolm.
You're right, Chair, so please bear with me. Yeah, I'm Malcolm Hall, for those who don't know me. I'm Acting Director of Finance, Performance and Contracting until Jenny joins, as James mentioned, at the end of August. So you're going to have to put up with me for a couple of months, unfortunately. Thanks very much. So just by means of an introduction, I'll take the paper as read. Just the main points I'd like to mention, obviously, this is the first month of the new look Integrated Finance and Performance Report that's prepared using the SPC charts. It's been reviewed in a lot of detail at ELT and Finance Committee, and I think it's been really interesting, the change in the level of discussion and the dynamics around the discussion since we've changed the reporting process, and I think we've got a lot more engagement, and we're definitely focusing on the right issues now moving forwards. The one thing I just think I do need to say is that I think there needs to be appreciation that this is still a relatively new process for the trust, and you know, where certain targets have been missed, I think there's been the appreciation in the discussions at the LTM Finance Committee that some of the commentary does need further development and refinement, and that will happen over time. And you know, I'm expecting things to be vastly improved for the next reporting, which will be in month 2. That's all I was going to say in terms of an introduction. There was one specific question which I'll take next, which was around assurance on the QUIP programme. Yeah, on that, I mean, I think in terms of a positive position, obviously, as people will see from the paper, the overall target's 11.7 million. The latest position is we've got 11 million pounds worth of schemes identified, but I think the key thing is that there's an appreciation we've got a significant delivery risk against certain elements of the plan still at the moment. We've still got £4 million worth of schemes that are red reg rated. Just about managed to get that out okay. But we're expecting that to come down significantly after our next QIA panel in June, because we've still got quite a few schemes to go through there. And in terms of additional assurance, in terms of the visibility, just to reassure the board, we have got a weekly QUIP delivery group that meets to review progress, discuss new ideas, etc. And there are still weekly updates on this provided to ELT, as well as the monthly update to Finance Committee and the board. That's all I was going to say as means of an introduction. I'm happy to take any further questions.
Okay, thank you, Malcolm. And just by way of a short test, do you want to tell us what QUIP stands for? Quality Improvement. We get used to the acronym, you see, and if people are watching or they're coming to the meeting later, they're going to say, oh, I wonder what that was. It's quality improvement saving, isn't it, basically?
It is, yes. Thanks, Angela. Do you know what? You're right. There's so many acronyms. It used to be CIP, cost improvement programs. Yeah, but we did get used to the acronyms, and we should make those very clear in the papers. So that's a fair point.
They are at the very back of the papers. Jane puts a glossary, but I know when you're kind of listening to the meeting. And the other thing is that everything goes out of your head, doesn't it, when you sort of think about what they stand for. But thank you for that. What I want to do is just also invite Jitesh to put the report from the committee, the update, onto the table as well, and see whether Jitesh has got any points he wants to raise. And as we did with the previous report, we can kind of take a broader discussion both on the presentation and the points Malcolm's made, and on the report from the committee. I'm saying, Jitesh, I hope so. I know you're having connectivity problems this morning. Are you able to at least join us, if not with your camera? No, I think Jitesh, I had seen that he was there earlier, but clearly he's not able to join. He's been in some of the conversation that I can see on my screen, but clearly not able to do that. What I will do is I'll just put that on the table as well, the update following the Finance Committee. So Malcolm, if people have got questions on that as well, you and I might be able to help with those, but assume that that paper has been presented. That's from the Finance Committee, and we'll hope Jitesh can join again later. James, you wanted to come to.
Yes, Chair, I suppose I would just reflect that as slightly going to Clive's previous question, I think we've got probably quite an exciting year moving forward in understanding our operating performance by virtue of the fact that our board KPIs that are reported through to the Finance Committee will be seen and shown in SPC, so statistical process control, which I would flag to the board was quite a helpful and invigorating conversation as part of the executive team from both an educative point of view and actually what are we doing to try and improve and maximise the nature of the way we deliver health and care within our organisation.
Yeah, on the presentation of the actual integrated report, I think I commented at Finance Committee that we'd known it was coming and we've seen it, but it really does look quite different, not just visually looks different, but in terms of the way that it brings questions to mind. And so I think we're going to get quite a lot. I think, Malcolm, you made this point, we're going to get a lot out of this as we use it more. So I'm going to other questions. Now, I know, Kathy, you've got a question that you're going to present to us about waiting times. Shall I take a couple of other questions on what's presented first and then come back to you?
Yes, happy to.
So Jane Slatter.
Thank you, Chair. It wasn't so much a question, was a comment about, I was a bit discombobulated when I first saw the new format, but actually got very familiar with it very quickly. And I think it's very useful in the sense that it really highlights the strategic issues that we have that are, you know, we've known about. So our clinical vacancy rate, we know our sickness rate has been an issue, but then, you know, we've had a pandemic, so we know that's been contributed to by that. But also our 18-week wait, which Kathy's about to discuss. But it really sort of highlights those things for us, which means that we can look over a longer period, and I think will be really helpful to us in the way it is at quality. To look at this on the finance dashboard is really useful. So thank you, Malcolm.
Shall we go to Kathy's contribution now then? Kathy's going to tell us about the 18-week waiters. Kathy.
Thank you, Chair. Yes, so I'm referring to the Trust KPI number 15, which is the percentage of all Trust patients seen within 18 weeks. And as people will be able to see from the document, that our achievement for that is at 74.1%. And has been within a particular variation now for some time. Colleagues will be aware from previous discussions here at the board meeting that we have discussed the performance related to this and the impact that the COVID pandemic has had on waiting times, the fact that staff from some of these services had to be redeployed, but also some of the changes in our infection control practice meant that we were unable to undertake group activities. One of the things that I wanted to do today, we are asked as a trust to confirm at board meetings our position around 104-week waits, because there is a real drive nationally, obviously, to ensure that we don't have those, but if we do have them, that we have a plan. So I would like to confirm, as an organisation, we do not have any 104-week waiters. What we do have, as you can see, is that we do have waiters, people waiting beyond 18 weeks, and we do still have people waiting above 52 weeks. And what we have seen this month is a reduction in our over 52-week waiters, but we do still have challenges between 18 to 52 weeks. What you'll see from there is we've got some particular challenges in our outer northwest London part of the organisation. So that's particularly in Brent and Harrow, and the challenges there are particularly with speech and language therapy and also podiatry. So we've got some particular work going on there. So we are also, as an organisation within the executive team, having discussions around the potential for further investment into those services to help clear some of those backlogs further. But we are just waiting to see where our contractual agreements land so that we know the financial possibility that we might have to put in additional resource in the next couple of months in those areas. Thanks, Chair.
Kathy, thanks. And I don't know whether it's back to you, but it's something that I want to just pop into the discussion, and then I'll call other colleagues. Of course, one of the things we've tried to do as a trust is to always think about how we address population health inequalities, and that how we address the waiters can often show that we have some of our most deprived communities have got some of the longest waits in them. Of course, for CLCH, much of the work we do is with areas where there are pockets or indeed considerable deprivation. So I suppose my question is, and it might be to other colleagues, to Joe or others, are we able to take into account any of those inequalities questions when we think about trying to catch up with the waiters? I'll leave that one sitting for the moment, and I'll call in the other colleagues, and then maybe Kathy and others might want to address more than one question. Carol, please.
Thank you, Chair. And my comment is a more kind of overarching kind of concluding comment. Do you want me to make it now before we dive into some of the detail?
Probably hold it, because it looks as though there are no others. So if anyone wants to help me with the inequalities in waiters, I'd be happy to hear a bit more. Joe, please, and then back to Kathy. I'll come to you, Carol.
Sure. So I think we're at the beginning of thinking about inequalities in waiters, as is the wider NHS. And we had a really interesting presentation from Campaign 1 at the Equalities Group 2 or 3 weeks ago now, wasn't it? Looking about how we can use artificial intelligence, the weighting of personal demographics on waiting lists to make them dynamic. At the moment, a lot of this is under evaluation. There's university evaluations happening, but there are models starting to emerge, Angela, that we've noted, we're paying attention to. And my sense, colleagues told me at the group, was we were quite interested in saying, well, how do we bring that into the trust and implement that? So it was sort of surfaced at the Equalities Group a few weeks ago. Lots and lots of interest from me and from the Director of Public Health and from the patient experience team. So it's a work in progress, but that we are moving towards a much more dynamic use of waiting lists, use of prompts to manage DNAs, to enact the waiting lists. So all of that's in the system currently. So we can carry on doing work on that, and we will come to when there's something we think we can procure that allows us to have that sort of machine learning approach to this, because it is we wouldn't be able to do it just through our human resources, but we need some machine. But there are things starting to develop both in the management of DNA, which is what the equalities presentation is, but then the wider use of waiting list management.
Shall I go to Elizabeth now? Elizabeth Hale, and then back to you, Kathy and Carol.
Yeah, this was just to provide the board with an update on the requirement that we will have as a board around reporting in this area. So we will need to be able to report our waiting times, both in terms of ethnicity and deprivation. And we are proceeding with that work at the moment. It is very complex, but we are nearly there. So we will start to get reports at board level, and that is a requirement.
Good. I'm going back to Kathy, and I'm thoughtful about the diabetes work, which has begun to kind of dig into that. So, Kathy.
Yes, so just to build on the comments from Elizabeth and also Joanne, we have already undertaken quite a detailed piece of work around the did not attend rates for diabetes, and what we have and we've covered that from two angles. So the first of those is where we know we have high levels of diabetes, are we seeing appropriate levels of referrals into the services? And secondly, where we have people who do not attend for their appointments, are they perhaps some of our most vulnerable communities? And we've already undertaken a piece of work in out in North West London, so in Harrow, also looking at that as a piece of work in our Barnet services. And what we are seeing is that there are certain elements of the population who are more likely to not attend appointments, which is leading us to really particularly think about how we're communicating appointments. Are we ensuring that we are covering all bases in terms of where English is not the first language, and or some of our more deprived communities, and where we're making assumptions around text reminders, and is that an appropriate reminder system for people? So we're already undertaking that in terms of do not attend and actual referrals, but as Jo and Elizabeth have said, we've undertaken a much broader piece of work which will then in more detail cover our waiting lists and the lengths of times that people wait, and for particular types of services. It's quite an involved piece of work, but it's going to be incredibly important in terms of how we address waiting times going forward.
Thank you, very helpful, Carol. And can we take this as the last comment then on this item?
Thank you, Chair. Just very briefly, I wanted just to say, as we conclude this item, Malcolm, I really welcome the revised format of the financial and performance report, and notably the added value in terms of insight which SPC is providing. And I would simply observe it's very timely as our medical director leaves us, and that she can see that we've embedded this not just in our quality committee metrics, but also in our finance and performance metrics. And indeed, I wonder whether offline, Billy and indeed Jane, we might shamelessly steal, in a spirit of continuous improvement, some of the presentational aspects of this report for our respective committees. So it's just a thought, and then we can get some consistency as well across how the committees report. So I think this has been invaluable. Thank you, Chair.
I think that's a really good challenge to us all, to use it to its maximum, this new way that we're thinking about things. And the very fact, Malcolm, I know it got raised at committee, didn't it, that we look at it in a different way, has promoted a discussion here, I think, that possibly wouldn't have come out of the performance aspects in quite the same way. I'm about to close this item, but I'm just going to invite Jitesh, if he's here. I can't see him on the screen. No, I'm afraid not, but Jitesh would have presented the report, but it is there for the record. Thank you. We'll close that item. We'll move to 3.3, and it's back to you, Malcolm, on organisational objectives, key performance indicators.
Thank you, Chair. I'll take this as read. I mean, it links in very much to the last item. I mean, I don't think there's too much to say here. As I said, take it as read. I mean, this is basically just setting out the final agreed 22-23 KPIs and their owners. It just builds on, I know there were reports that came to board in February and March working this through. So this is just the final version for note here at the board, basically. The only other point I was going to mention was there was two questions, both sort of under Luella's remit. So look, I've spoken to Luella Johnson, and she's going to pick up those two questions that have been raised for us.
Thank you, Malcolm.
So I'm off to Luella. Thank you.
Thanks. So on page 139, reference is made to the new objectives, and in particular, the appraisal quality rate, and when might we expect to see this worked up and ready to use. So it's we have looked into what questions we might need to ask of staff who've been appraised to understand if their appraisal was of high quality. We've also looked into whether the existing iLearn appraisal module can be adapted to enable someone who's been appraised to easily click on a button and then answer the questions. And with regard to that latter, it's speaking to the providers of the app, it's the software rather, it is likely to be a technically clunky solution that is more likely to put people off making the extra effort to give us a response. So what we're looking at instead is piggybacking on an email that goes to all appraisers and appraisees to say your appraisal has just been submitted, and what we're considering doing is putting a link into that email which says to an individual, would you like to fill out this form? And we're going to make that form as easy as possible, a Teams form, easy as possible to fill in. It would be a mixture of quantitative as well as qualitative answers. So it's 5 questions which you can strongly agree with right through to strongly disagree with. And we will be able to then quantify how people viewed the quality of their appraisal. And we will allow as them to use free text as well. That will then allow the data to be collected in a spreadsheet, which is more readily analysed. So that's where we are at the moment. In terms of how long it will take us to do, it's probably the thing that will take the most time is getting those questions right and into an MS form, and then testing it with people before we really launch it big time here. So I think it's going to take us 2 to 3 months to be sure we've got something that is going to be welcomed and not irritate people and be seen as something burdensome. So I would hope that we start using it from October formally. Should I pause there and see if there's any questions?
If you take the next question, and then I'll just pick them all up.
Okay, so the target for staff recommending CLCH as a place to work hasn't actually changed. It is still 62%. I think what might have been misread is that it's 80% is the target for staff recommending CLCH as a place for treatment. But it is a target that it is challenging, the 62%. And the refreshed people strategy that we've been working on and will bring to board in July has a number of outcomes that together are very much focused in on how we make CLCH a great place for to work for everyone. And that in turn will be a place then that they recommend as a place to work. So for those who are involved in the people committee work, you may recall that several of the things we're looking at is how we have fair, consistent and robust people management practices, how we make staff feel they are valued and cared for, how staff feel developed by the organisation, and how all staff model our values in their daily behaviour. So those are the outcomes we want the refreshed people strategy to achieve. If we achieve that, we should make CLCH a great place to work and a place that staff recommend as a place to work. Should I stop there?
Thank you. What I'm going to do now is take any questions or comments on 3.3, the whole paper, either to Malcolm or any follow-up with Luella. Carol.
Thank you, Chair. Let me say the first question to which you provided an answer, Luella, was mine, and this was about the appraisal quality timescale. So you've answered that. Thank you. Just as an aside, you described a process which will enable you to get some feedback. So I'm really keen to avoid the operational weeds, but just thinking about how that would work in practice to ensure people understand why we're asking it, that whether there's anonymity involved, etc. So, but I'm just leave that with you in terms of rolling that process out. But thank you, you've answered my question.
I don't think we need to answer that now. We can take the answer to that, I think Carol's saying, offline and as it develops in the way you've suggested. Thank you. Yep. No other questions or comments on 3.3. I don't think we need to agree these again because we have agreed them, but I think we need to note that they're now open and available to be published. That's probably the main point now on the objectives. Okay, if we note that then, and then we'll go to 3.4, which is the report on our agenda, COVID vaccinations and a variety of service updates. Am I going to Kathy or Joe or Billy first? To Joe first, thank you.
Before I go through this report, there are a few things that have changed, and I just want to steer Angela. Would you like a brief update on the Trust response to monkeypox?
I was hoping that you would do that as well in the report. Thank you very much.
I thought this was the place for it rather
another
than
virus, another day.
Another virus. So in the 10 days it's taken for me to write this, and things have moved on, and as we know, there are other things occurring. So first of all, relating to COVID, things are really stabilising. The prevalence rates are dropping. As a result, the NHS has moved itself from its top level of incident preparedness, level 4, we are now in level 3. And that's always reassuring. I said, of course, we should really be at level 1, but we're at level 3. And what level 3 means is that we respond to regional guidance around how we manage the ongoing COVID incident in its 2.5 year. But things obviously around COVID are much calmer and much more stable. However, as you will have heard from the news, we've also had issues regarding a pox virus called monkeypox. And the first case was discovered on the 7th of May. And I've just got in front of me the update from the gov.uk website. There were 77 cases in England, yesterday 78 across the country. There was a case discovered in Scotland a few days ago. So 78 across the country. I think the reason why the Trust then had to respond quite significantly this week is we've had 4 cases identified in one of our sexual health clinics, and we've had a member of staff. So of that 77, 5 have a connection, either patient or staff, with CLCH. We're not sure whether this is something to do with place, so we escalated a couple of things just for the reassurance of the whole board. We've started having daily meetings. I was in discussion with the regional medical director. James briefed the regional chief executive and our North West London chief executive as our commissioning lead. We have very quickly brought out screening questions for the affected services, which are predominantly our walk-in services, so the walk-in centres and the sexual health services that still do have an element of walk-in to them. Screening questions, and then for because people who have been in contact with that full PPE on, which is mask, personal protective equipment for the minutes, they have to quarantine for 21 days. So we also had 8 members of staff affected, and then we had to work and find how we got a thing called PEP, which is personal exposure protection, post-exposure protection, which took a little while, and it's actually the use of the smallpox vaccine. So we got that agreed by Tuesday. Staff have been linked into the 2 major hospitals in London who are providing the PEP, so we'll get their smallpox vaccination as that gets timetabled for them. We are having regular incident meetings as we did with COVID, and we're keeping a very close eye. James has asked me what my view of this is, and I think it's difficult to say at the moment. This might just be a little cluster of a new disease that burns itself out and settles. I think until a bit more time passes, it's difficult to know. We are just making sure that the Trust has geared itself up to respond to increasing case numbers, but at the moment we're probably in a sort of watchful waiting position. So really, that is all I want to say on monkeypox. There's still no outbreaks on our services for COVID. And just one matter for clarification around IPC. In the previous update I did to board, I said the Trust was unmasking in its non-clinical areas. North West London did review that position and asked that all the providers within that North West London footprint stay masked, and the Trust responded, well, we are staying masked currently in all of our areas unless you are sitting at your desk, you're not moving, and you're 2 metres apart from a colleague. So that is the position, Angela. Thank you.
Thank you, and thank you for the update on monkeypox. I suppose one of the points of learning from the early days of COVID is that you can't assume that things will be small and insignificant in their numbers. You've got to now, and we've learned that lesson, but let's hope it is just
we're preparing for the worst but hoping for the best. I think that's the summary position.
Spot on. Kathy or Billy next? Kathy.
Yes, I'll come in, Chair. So as Joe has said, from a COVID perspective, we have increasingly returned to a business as usual position. And Joe's just mentioned we haven't had an outbreak in our bedded areas for some time now. We have reinstated group activity, and our waiting room infection control measures have shifted so that we can have a larger number of people waiting, but we encourage patients attending to wear masks. So we are seeing a return to that activity. But of course, this week, with the increased attention on monkeypox, we have had a review of those business continuity arrangements just to make sure that everything is prepared should we need to consider how we manage services differently. And of course, that's particularly important at the moment for our sexual health services and our South West London Sexual Health Service, where we have got that absence of staff due to the need to isolate. But otherwise, from a COVID perspective, we are in a much more settled and contained place and returning to those business as usual activities.
Billy.
Thank you, Chair. Nothing additional besides what is going to be mentioned. Besides that, just outlining that our COVID vaccination numbers are outlined on page 142 at the end of our of March. That's the last time we collected those numbers, and we're getting ready for the spring booster for over 75s and supporting the PCNs with that. But we keep a close eye on what happens going forward in terms of vaccination work. But nothing more to add besides that. Thank you, Chair.
And more will emerge as we know more about flu and so on much later on in the year, won't it? I don't see any questions or comments, so I'm going back to you, Joe, if you want to make some additional comments.
Just the recommendations at the end of the paper, again, honestly, 10 days is a long time. I was recommending that this paper now ceased because we're going back into sort of normal rhythm. This was an extraordinary update paper that we did across the COVID period. However, because of where we are with monkeypox, I would wish to withdraw that recommendation, and I think we hold the paper at least for another month.
Yes, I thought that we were going to say thank you all for all these wonderful reports you've given, and we need no more, but let's just hold hard for another cycle. Okay, thank you all, and let's note that report. I'll now move to 3.5, which is the staff survey 2022, and I'm going to Luella.
Thank you, Chair. So the update on the paper as it's submitted is that on the 24th, ELT did have a discussion about the 4 trust-wide initiatives, which were together aimed at achieving a number of outcomes. So tackling bullying and harassment, continuing with the themes around team working, morale and well-being, and also staff engagement. So the OD and culture team, with help from NHS Select, did further analysis of the staff survey and also held a number of working groups, came to the conclusion that these 4 initiatives would help address and continue those specific staff survey messages: staff engagement, morale, team working, well-being, and preventing bullying and harassment. So it's those together that we debated and concluded that those initiatives probably were the right things to do. We needed to do them. And what I think we all reflected is that this is not about a quick win by the next survey, but it is about making progress before the next survey, including giving our colleagues assurance, evidence that we're taking what they tell us through the staff survey seriously. The specific question about the locality plans and when they would be completed, we also discussed that at ELT on the 24th, and have asked all directors to bring back their directorate staff survey action plans for review and review on the Wednesday, the 7th of June. So our commitment to our staff was that we would publish the plans in June, and I think we can still meet that. We are taking very seriously the need to consult with them. So we have given ourselves a couple of weeks extra to make sure that people are able to complete that consultation, however they might need to do that. And I think if I look back over the reasons why there have been delays in talking with colleagues, it's a combination of things like sickness absence. Organisational change at a senior level has also played a part and made it a bit challenging to get some of that consultation in place and seen to be led by the director and senior management. But I think we will get there with good plans, which when they're published will give our staff confidence. Happy to take any questions.
Thank you, Luella, and thank you for emphasising the importance of kind of listening as well, because we've got to keep listening as we go on this down the road, haven't we, on this? I'm looking to see if there are any questions or comments. There are none, so can I thank you for that, and we'll note the report. I'd like to move then to a 3.6, promoting equality and tackling inequality. And this is a Q4 update, and I'm going to Billy for this one.
Thank you, Chair. I think first I'd like to just thank members of the Trust and people who are engaged in this agenda, because I think from when we launched the strategy, we've seen a marked increase in engagement, particularly some of the successes we've had. For example, we've now launched our Staff Equalities book club, and the numbers that came through to join that were double what we expected, and some really in-depth, honest discussions staff were having around equalities and how it made them feel and what it means for us as an organisation. So I think it's important just to mark the people and their willingness to be part of that process. But going back to the report itself, this is an update on the strategy that we launched a few last year, and what we have in there is updates on our 4 campaigns to access to services. We've talked around the DNA rates and the binary diabetic services and how we're getting volunteers in there to support in terms of improving the DNA rates. We also got the workforce equality work stream, where we're looking at better outcomes for our staff and recruitment retention and our promotion data. And also the Staff Equalities Book Club is part of that work stream. And then understanding of our communities, we've talked about the targeting areas of deprivation and understanding the communities we serve and how we're supporting those people and how our services are working in those areas. And this report outlines what our work and the successes we've had so far in rolling out that campaign. And then our role as an organisation. Anchor organisation is another area that I think is something that we can really smile about and be happy that we're engaging with our commitment to support recruitment for our local communities. And there's a targeted piece of work we're doing in there where we're supporting 17 to 25-year-olds with SEND to work experience. And I think that's something that we can be proud of in terms of our role in that as an organisation in the system. But with that, I'm happy to take any questions or comments. Thank you, Chair.
Thanks. And it does refer us back to saying we'll have a look at that NHS Confederation framework again to see how we're doing. I think we probably have incorporated that and moved on, but we'll go back and look again. Excuse me. Questions or comments? There are none. Can we then note that report, please? And we'll move now to the CLCH Way Change Programme, the full report of the programme. Elizabeth. Oh, sorry, Jane. Did you have your hand up?
I did. I was moving. It was just to provide some feedback, really. I think there's some absolutely super initiatives in here. I was particularly taken by this initiative that we might have tackling unacceptable behaviour campaign within the workforce. Which is around being respectful of each other and also thinking about bullying and harassment. So I'm looking forward to see how that develops. I think the other point I picked up from this paper is that we need to keep investing in our networks and the chairs of those networks. And it is a bit discouraging to see that we've lost a few of those chairs or they've stepped back. And I think we really do need to spend the time understanding why they've done that. Because I think, you know, they are key to progressing, you know, our sort of equality and tackling inequality strategy. And I think giving them the training and the right support and potentially the protected time to be able to carry out the roles is extremely important. So I think, you know, in re-looking at filling those roles, I think we just need to think about our strategy there. And that was my only comments, but I think there's some super things in the report. Thank you.
Thanks for that. And James, you wanted to come in.
I completely concur, Jane, and I've made it expressly clear that it is my desire that the chairs of the committee are given protected time. They are to be job planned and that time is to be put aside. And if it is not, then I would like to then address that with the management team.
Yeah, lots of nods around the screen. Thanks, on that.
Jane.
And I know, Billy, that would be something you'd want to take forward. Noting the report, I'm looking around the screen a bit more carefully, see if I've missed any other hands. Don't think I have on this occasion. So we will go to the CLCH Way change report. Elizabeth, please.
Thank you, Chair. There were no specific questions sent in advance for this, so there are just a couple of things that I would like to draw out. The first is within the report section 3.4, which really focuses on the benefits that we've got from these change programmes and how those benefits, primarily from digital programmes, have seen an impact on the lives of staff and in the care that our patients receive. So those initiatives are things like patients being able to do their own bookings online, our ability to do virtual appointments and also remote monitoring for patient care, and the significant improvement that we've seen in the quality of information that we are now able to share, not just with board, but with staff at all levels throughout the trust. I'd like to note the leadership and give thanks to Duncan Dewhurst, our Director of Transformation, for leading this work. He will be leaving us at the beginning of July and is taking up the role of an Executive Director with Buckinghamshire Healthcare, where he will be Chief Digital and Information Officer. So again, I think it's somebody going on with good knowledge and expertise, having developed in a community trust and taking that with him elsewhere. But a big thank you, because a lot of the achievements here are down to his leadership. The second thing that I would just like to draw out is section 5 in the report, which notes the external recognition that we have been developing over the past year for the change initiatives. And one of those in particular was our QI conference, where Hugh McCoy, the National Improvement Director, spoke to us and gave a keynote speech from NHSEI. Now, what he talked about very passionately was infusing staff right across the organisation and making sure that all staff, all 4,500 of our staff, are fully engaged in an improvement journey and not just doing their day jobs. And I think that is where we are now going with our change and improvement programme. So I think what we're going to do now is build on the success that we've had with the CLCH Way and the change programmes that we've had. But in building on that, we need to think about how do we integrate and fully involve everybody in that process, and also really fulfil the board level commitment that was made through our Leadership for Improvement programme that we had as a board, looking at how we can lead quality improvement across the trust. And I think, you know, we will build on some of the things that we've started to see through, most notably the SPC charts that have come very recently, which arose from that programme and are already showing a benefit in terms of us being able to target our efforts where they're most needed, and we will see most benefit in improvement. So those are the things that I wanted to mention. Happy to take any questions.
And thank you for dealing with the questions that came in advance. So are there any other questions or comments people want to make? Carol.
Thank you, Chair. Just very briefly, Elizabeth, there's some really positive progress here. So just to kind of acknowledge that, I think it's very encouraging, despite the kind of hindrances of COVID over the past year. And just to recognise that CLCH is the first community trust to integrate doctor-doctor with System 1 and EMIS, so fantastic. So much to celebrate, and I'm assuming it is a real sign of our maturity that the QI function is now kind of become BAU. So I'm taking that as a good sign. Thank you.
Thank you. Thank you.
Yeah, I just thought it was interesting that we now see it as BAU, and we won't lose that enthusiasm. And we know that the enthusiasm is shared very widely, because those of us who were on that conference call will know that we had many people from other parts of the UK, and indeed 2 people from 2 African countries who joined on that day. And there's that kind of community of interest that spreads right across people involved in all parts of public services, really, social care and health for us particularly. If there's nothing else, can we then note that report? And I will then move on to the 3.8, which is learning from deaths, Q4, and that's Jo Medhurst, please.
Thank you, Chair. So this sort of sets out the data that we described earlier, which had caused a little bit of confusion with the KPI. So you've got the number of deaths that's either on our caseload or within a week of discharge is what the numbers here show you. So January, February and March. And then we do deep dive reviews or present reviews on anything that dies that's got a concern or is in our bedded area. And you can see there were 5 of those. We then record what's going on in our Homeless Health Service and around learning disability. That's a different process called the LEDAIR process, who has got some issues, but people are working that through, and we keep an eye on that and support partners where we can. We've got an update on the medical examiner system. So this probably went into statute about 2 years ago, but I think it is very slow to get off the ground, the impact of the pandemic. And as you can see, there's some issues around how you do record sharing around confidential patient information between organisations, which the organisation is working through, but it's moving forward, but we still haven't quite landed that yet. And then lastly, just to update the board, there's been a national expectation that we look in much greater depth at any death that was linked to COVID across that pandemic period. So we have a process to that. We're linking in with the North West London medical directors who are doing that across the North West London deaths within the system. We have agreed some resources. It will be led by the clinical directors across the divisions and make sure we fulfil our expectation of learning across that period. That's it from me, Chair. Thank you.
Thank you. And I certainly remember when the medical examiner piece started, we thought that we were going to be facing that very quickly and preparing for it. And of course, it's just been almost impossible nationally to address that. Questions and comments, Carol?
Thank you, Chair. Joanne, I wasn't expecting to have any questions from this paper, but it's prompted a few, so will you forgive me if I just go through them? The first is regarding the risk associated with paragraph 3.5, and this is about the backlog of reviews at CCG level. If David Signs, our past NED colleague were here, I know he would want to have some reassurance around that, and I see that the group is meeting today, so don't need the detail necessarily, but if there's anything that suggests this is an ongoing delay, it would be helpful just to hear about that offline. Is that okay? So is that all right with that one? The second is regarding the resuscitation training levels. They are close, but still technically below our target. So the question is, are there any implications or risks as a result of this? In other words, we're not hitting the target. I suspect there's not, but it'd be good to have the reassurance. Shall I pause there to have that reassurance from you?
Yes, I mean, it's always good to hit the resus target, but because clinicians get updates either every 1 or 2 years, depending on the level. So it's an ongoing incremental update that I think it is safe, Carol, to have some tolerance within that year's deadline. I think the area which maybe we don't address here and we could look at, Billy, is that there any clinicians that are actually over maybe 4 to 6 months, because it's that length of time since your last update that becomes the issue. So I can't answer that, Carol, because I've never thought of it until I said it out loud just then, but I'll take that and I'll just make sure that we've not got anyone. It's a bit like the waiting list time, isn't it? You've got some tolerance between 52 weeks, but you hit 104 and your tolerance stops. So I'll see what the bandwidth is and whether we need any actions on that.
Thank you. And then my final question, which I'm happy to take offline, Joanne, is at page 195, drilling down to section 3 and the patient death in Q3. And if I've read the report correctly, there's reference to this case, this particular case, being judged more likely to be due to problems in the care provided to the patient. And I just wondered if we'd exercised our duty of candour with respect to this. So as I say, happy to take it offline unless you want to pick it up now. Thank you.
Yeah, I get the discussion about duty of candour is within the policy and within the process. So I feel assured they will have discussed it, but I can get you an update from the chair, Carol. So I'll send that to you personally.
I'm going to move to Billy as well, but can I just say to colleagues, there are questions covered in the chat, and the duty of candour is one of those. So what we'll do is we'll make sure they are taken up offline, as Joe has suggested. Billy.
Thank you, Chair. Just to come back on Joe's comment around the training, we will look at those numbers as Joe suggested. But I wanted to reassure the board that as part of our research contract, every time there's a research in any part of the organisation, we do a thorough review of that research to ensure that there's timely learning for all staff concerned. And so we don't wait for the annual review or annual updates to the training, but also do timely and real-time training for the staff on the ground and reflection on what happened, so that we can capture that learning in a timely manner. So just reassuring that we are on top of that as well, just ensuring that staff are competent and are supported for the research. Thank you.
Thanks. Are there any other questions or comments on this report? Hugely interesting and important report. Thanks for presenting this and for the questions that we've had. And I think probably, Carol, Quality Committee will take at least some of those in terms of learning, which is what's suggested in the chat, I think.
Thank you.
Okay, on that basis, do we note the report? Thank you. Let's then move to 3.9, the update on the Green Plan. Elizabeth.
Thank you, Chair. So this report comes to the board twice a year, and it just reports the progress against the Green Plan. As you can see, we've been making good progress in the first year of the plan in terms of what we would call the quick wins. So things like putting in LED lighting and improving some of our insulation. We're now going on to do some of the larger investments in installing ground source heat pumps and looking at where we can put in place solar panels. For staff, one of the key changes has been a move to electric vehicles only for the car leasing scheme. We are installing electric charging points. So the report outlines good progress. I'm happy to take any questions on that. I had none in advance. I think the thing I would just like to note that I'm most proud of is that we have got 60 very active green champions, and we are hoping to grow that network this year, as clearly the issue of climate change is not going to go away.
And I think it's very interesting, isn't it, Elizabeth, that it's part of really quite a lot of staff are quite motivated by their participation in being green champions.
And the critical link with health as well, you know, the consequences for us as a health service.
Yeah. Questions, comments? If none, let's note that report as well. And I'm now going to move to 4.1, Research and Development Annual Report, and that's with Billy to present.
Thank you, Chair. This is a comprehensive report, aspects of which are already covered in the quality report. So I won't go into detail and open up to questions, but just highlight that during COVID, we've had some great engagement of research from our teams, and we are working in partnership with a number of universities, both in research and training, and also access to libraries. So there is great engagement, and our staff are really engaging with that agenda. and then signpost to page 226, just one of our shining stars there, one of our nurses, Agnes, who's leading a piece of work on lower limb wounds, which is an area that I'm more passionate about in terms of our trying to support people in those areas. So just highlighting the work that we're doing there to try and enhance our care and our practice in relation to that piece of work. But happy to take any questions.
I think we've always had the aspiration, I'll come to you, Jane, in a minute, that we will be amongst community trusts absolutely at the forefront of research and development. And I think, you know, what happened in the 2 years, one of the many things that happened was that we fell back a bit, all of us probably, in our research programs. But I do think that we're going to step it up. I think it's really important. Jane Slatter.
No, it's just to say that we saw a presentation from Angus, or heard about Angus's work, and she needs to be commended for her resilience and her determination to keep going with her research project and the fantastic results that came out of that. But it's really good to see that the early steps are appearing, the green shoots are appearing on the research strategy that we've agreed and laid out at Quality Committee, and we've agreed at board. And hopefully we can get that motoring again now. Thank you.
Yeah, I couldn't agree more, Jane. We've got to get it going again, haven't we? Any last comments from anyone or questions? If not, let's note that report and we'll look forward to a kind of trajectory of taking off again during the year that we've just entered on this work. So 4.2 now, all trust risks annual review. Billy.
Thank you, Chair. So this annual review just outlines the number of risks that are currently open on our trust risk register. Our risk register remains a live document that all members of the organisation can update and add risks to. And we've got robust systems in terms of our governance structures to review and approve risks from the low-level risks to the high-level board assurance framework risks that come to board regularly. On the report, it just outlines that the highest numbers of risks that we have, we've got the highest clinical related risks sitting at 132 at the time of extracting this report. And there was a question received relating to why there's an increase of 38% from 8 in 2021 to 11 in 2022. I think just there's no scientific answer to that. It's just that it just varies in terms of what risk emerged at the time. But we know at the time we've had a number of change initiatives that have led to new risks coming online. Also had some staffing concerns in some of our areas that also came through as risks, and also the transformation areas that we're working through, and including IMIS, that's highlighted risks. But those risks were reviewed through our patient safety risk group, and we monitor the controls we have in there, and we agreed actions in terms of how we mitigate those risks to acceptable levels. And that's an ongoing process. Those risks, since being put on the register, they've now gone up again to about 11, back to where we were. So it just shows that it fluctuates, and we keep a close eye on that. And any risks that are on the register for too long, we would challenge and ask for work to ensure that there's a mitigated to an acceptable level. Happy to take any questions.
Yeah, I've seen one hand from James.
So I think this is one of those pieces of work that could value from looking at some SPC, because some of those variations are wildly different in terms of percentages, but when you look at the raw numbers, they are not actually that far. And actually, if you look into that, it's more some of the moderate risks that we might want to look into. But it's something that you and I can take away and have a conversation with Charlie about.
Thank you, Jane.
I think that's really quite important. Yes, Jane Slatter.
I apologise in advance because this is probably the type of comment I'd normally make as a member of the Quality Committee. And I know that we have got risks relating to COVID specifically, but it's just that flag about do we need to review or add a risk around monkeypox, and at what level we need to do that. And I'll say that because that's my operational colleague's job. Thank you.
Now we have talked about it, Jane. We're putting risks at divisional level currently, and until we see what the trend is. So we have talked about risk, and Billy's got it in hand.
Yes. Pox risks, yes. So there we go, but we'll look at it at divisional level. Thank you. Other questions or comments on the all risks register? No, if there are none, we will note that as well. And 4.3, our next report to board is health and safety, the annual review, and Elizabeth, if you'll present that, please.
Lovely, thank you, Chair. The report provides a good overview of the key areas that we monitor for health and safety, and in many of those there has been some significant progress over the past year. The key area to draw out where more work is clearly needed is for the display screen equipment assessments, which have been stubbornly difficult to shift from the about 50% when it needs to be at a much higher level to meet the target. We're in the process of procuring a new system which will be integrated with iLearn, and that we hope that that will help us to move that move the dial on that target so that we get more staff doing those assessments annually, as well as when they move from one base to another. There is one specific question that did come through in advance, which was about the threshold for the health and safety checklist completion. So if I could just say that the amber threshold for completion is 90%, but that actually our target is 100%, and clearly that's what we're aiming for each of our sites. We want all of the health and safety checklists that are undertaken quarterly to be completed. Interestingly, when I looked into this at the moment, we have got 3 divisions and corporate services that do sit at 100%. And we've got 1 division that's at 96%, so is in the amber area. It's just that for 1 division where they've got the largest number of sites and the most complex number of sites, with a lot of them being what we call tier 3 sites, where they're not owned by us and we only have sessional use, they are in the red zone, and so that is what's bringing the overall level down. So we'll continue to work with all divisions where it's needed to help improve, but as I say, I think we can see where we need the targeted support. And really, just in that spirit of continuous improvement, our focus now really is on making sure that we're tracking what's coming out of the checklists, and we've never really been able to do that effectively before. So the new system that we've got now will give us much better assurance that where issues are identified, that they have been addressed, and that we can evidence the action that has been taken, and I think that will be a real step change.
Thanks, Elizabeth. And very helpful explanation of the kind of variation between divisions, and this question of where we are sessionally involved in lots of people's sites run by other people, to shorthand it, is clearly always a challenge, isn't it? Yeah. Questions, comments? If there are none, can we then note that report, and thank you for the report, Elizabeth. And I'm now going to 4.4, which is the draft quality account, and back to Billy Hatifani on this one, please, Billy.
Thank you, Chair. This report comes here for approval, please. It's our annual quality accounts. We mandated to publish an account of our quality on NHS Choice website by the 30th of June. This report has been to Quality Committee and has been scrutinised and approved by the Quality Committee. It contains information we will have already seen from our quality annual report. And I think the changes, additional information you might have seen from that report is the clinical audit information that's contained in here. And just to note the work that our clinical audit program is up and running again after some pause during the early stages of COVID. That we paused some audits, but now it's up and running again, and we're reporting some great outcomes from that work. And also it contains some of the mortality data that we've already seen. So happy to take any questions on the report itself and seek approval, please.
One question, if I could put one on the table that I really probably should know the answer to, but forgive me. In the part of the report where we have to, and we do, seek comments from other organisations, if they come in very late on and they had a kind of major significance, what would we do? Would that go through you, Charlie, and Chair of Quality Committee, or it's just trying to think in advance? Because of course we have to do this in so many stages. If suddenly somebody shoots one across the bow, so to speak, how would we deal with that, Billy?
So I've written to all our partners. I've outlined the report, and I've requested they come back to us by the 30th of May. But bar that, to give them a bit of gives a bit of leg room between end of May to June to publish. But what we had last year was some of our partners came back a bit later with additional comments, and we responded to those and just fed back through our internal governance processes. But there is a process where we feedback and discuss through Carol and Charlie in terms of if there are any concerns are raised that we need to address. But those comments that come back to us, we do add them to quality accounts, and they become part of the account itself and our response to that.
Yes, that's what I was thinking, because those responses do form part of the account, and then we've both got to respond to them, and we've got to think about how we deal with any that come rather later than, people look at the end date and then start to do their response, unfortunately, sometimes, don't they? That aside, I thought it was a terrific piece of work, and thank you to all the people who've contributed to it, because it's quite a hard piece of work to do as well. Any other questions or comments? If not, can I invite the board to agree that this will be the quality account that we will publish, subject to those later additions that we've just discussed, comments of other people and so on? Do we agree that? Nods around the screen will do. Thank you very much, and thanks for all the work. So if we now move to almost a companion piece, really, the annual complaints report. Billy, this is with you again.
Thank you, Chair. So the annual complaints report accompanies the quality accounts when we publish, so we put it together. Just want to highlight that out of the 3 million patient contacts we've included in this report, which includes our sexual health contacts, we've had 174 more complaints. I think it just shows the level of complaints in relation to contact. We remain compliant in terms of delivering our responses in time, and we're active work in terms of working with our powers team to support families and complainants to ensure that we have the resolutions in a timely manner. We also feedback to teams in terms of actions and learning from complaints that come through, and the report itself outlines the themes emerging from different areas and what we've done in terms of the concerns raised and actions we've taken. I'm happy to take any questions or comments in terms of the report itself or any other information about complaints.
I'll look around for people to raise their hands. I have the initial, because it's an area that always interests me hugely, which just to say that I think that the way that we're handling complaints, which is part of, if you like, patient satisfaction or otherwise, if complaints are poorly handled, that's a very poor outcome in itself. But I do think that the response times and some of those process points, it looks as though we are actually working quite well in terms of giving decent, timely responses and inviting conversation. So thank you for that in the report. Now I can see a hand, but I can't see who it is. Yes, Clive, it's popped up at the top. Clive Sparrow.
On mute, Clive.
Sorry, Billy, I just wondered whether we are always on the lookout for new ways of ensuring that we make it easy for people to complain.
Yes, we do. Thank you. That's a very valid question. Our patient experience team is a team that's leading some of the equality work we're doing through our equality strategy. So we look at areas of deprivation, communication means, and how people can communicate with us and our role in the different communities we serve. So I think it's part and parcel of the learning we're doing through the equality work is really aligned closely to the complaints work, and we've not had any concerns around access to complaining. But we also have one of our patient safety experience leads come to our LD steering group just to ensure that we also look at different ways of how that access to services and raising concerns can be done to those most vulnerable, especially in our LD services. So I think in that we are quite open to ways of working and meeting our standards in terms of communication standards and how people can access those ways to complain. So I think, yeah, answering your question, yes, we are open to that. Hopefully that.
Because it is always the most vulnerable, isn't it?
Yes.
there are certain groups of people who have no problem complaining.
Just to add, that what I forgot to say is that this report also contains our compliments. So I think we always kind of focus on complaints and forget our compliments, but there is an element of some of the great work that we've received compliments for that is just worth noting as well. Thank you.
I was just thinking about really adding to this, and I'll come to James. As particularly non-executive directors on the board, we've had 2 years when we haven't been able to meet our patients and families in the way that we'd always beforehand. Now, clearly we'd never meet the largest number of people who've got complaints or compliments, but that soft intelligence, when we go around to the sites, we meet the staff, we meet some patients, always adds some richness and colour to these kinds of reports. And I think it'd be fair to say that all of the non-executives particularly have missed that, and we are pleased that we think we will be able quite soon, I'm looking at Joanne here, that we'll be able quite soon, and in fact, we have opened up the process by which, as NEDs, we can start to visit sites and be able to meet not alone staff, but some patients as well, which I think will just add something in that constant triangulation of what we find about people's satisfaction with our services. James, you had your hand up.
So I'm just going to Clive's point, but just to play to colleagues, I did discuss the broader report with Charlie around how through different lenses are we going to assure ourselves that we aren't seeing increases in complaints in some areas, given that when you can do a comparison year on year, whilst there has been some change in complaints, that could be explained by nature of organisational size. But when you start to dig into the data, we just need to do a check and challenge there's not issues in key areas. What I thought was most surprising on this was the lack of reporting of ethnicity. So the total number of complaints, when you start to drill down into this, we do not have representation, or if we do have representation, we have people who are unwilling to share characteristics, which is something you'll note in the paper at page 375 in red, that the inequalities team are going to be supporting the complaints team to look at how we might improve some of this reporting and actually understand what might be happening for some of our service users and residents. Because I would probably reflect back, there are definitely people who by virtue of characteristics may not be complaining, and we need to hear their voice.
That's a really helpful point, and I think is a very good piece to raise on Clive's great question, which is about there'll be people who complain, and then there'll be people who don't know they can, don't know how to, and we would learn a great deal, as well as hopefully offering them some greater satisfaction that their issues have been addressed. Anything else on the complaints report? If not, can we agree that report? And thanks again, Billy, through you to the team who deal with these and the teams who deal with the compliments and the PALS teams and so on. Thank you. Shall we then move to board committee items? These are under 4.6, where I'll ask the committee chairs if there are any issues they quickly want to raise from the committees whose minutes appear here. Of course, the agreement or otherwise of minutes goes to those committees themselves. But I'm going to start on 377 Quality Committee, January. Carol, anything you want to pull out of that one?
Nothing. We've met since then, so it's slightly historic now. No, thank you, Chair. Nothing.
And Clive on Audit Committee of April 2022. Are you unmuting, Clive?
I'm sorry. I must learn how to use this. There is nothing I want to highlight. Audit Committee, as always, we cover a lot of detailed issues with help from the external auditors, the internal audit team, and the counter fraud teams. So we get a lot of very useful independent support, but it's reflected in the minutes in the report.
So nothing from the minutes of April or indeed the January or February
No.
ones. Thank you.
No.
And Jane, People Committee minutes, and that's way back to November.
Yeah, so we have met, Chair, since then in March, and we are meeting again early in July. I suppose the only thing to highlight are at March we started to use our SPT charts in terms of looking at our data more intelligently. The appraisal rate has improved considerably since these minutes, which is great. We've had our seminar about the refresh of the HR strategy, and that's being worked on, and we'll be coming back to the board with that HR strategy refresh for discussion in July. Okay, thank you.
That's very helpful. I wonder, Jane and Jane Walbridge, whether you want to consider whether the People Committee ought to have a short update following committee, which Finance and Performance does and Quality does. So I'll leave that with you to have a think about. Because you say the minutes, you've met lots of times since, you've done lots of work, and the minutes are a bit aged, aren't they? By the time they get to us. Jane Walbridge.
Yes, it's just a cyclical thing, Angela. There will have been a report to the board from that November meeting nearer to the date. It's just a cyclical thing. We have got that process.
And we'll make sure then that the most recent, if they can get to us a bit more quickly, but the trouble is, it is the cycle, isn't it, of meetings. Okay. If there is nothing further on 4.6 and those board items, I move now towards the end of the meeting, and this is something that we've always promised ourselves we'll think about carefully. First of all, I'm going to ask Jane Walbridge whether there are any risks or priority topics that we've identified during the meeting that are additional to anything that was already in the papers.
Only the monkeypox virus issue, about which action has been agreed.
Sorry, I was doing it then, Clive, chatting away to myself only. I don't think anyone else has picked anything up. So can I then ask, hugely important, particularly of NED colleagues, but not NEDs alone, are there issues or items for which we require further assurance? Other than those, obviously, that are already in our progress? No, if not, thank you for that. I'm going to leave just a moment now. We always want to know what observers of the meeting or whatever think. We're not in an interactive meeting, but I'm just looking, Jane, were there any questions or comments raised in the chat that would help elucidate what's been happening and add to our learning?
I haven't seen any comments in the chat, Angela.
Okay, so that's helpful to know. And then we will just move to the very last item, which is to say the date of the next public meeting is Thursday, the 28th of July. And I've got rather tired of saying the next one might be in public, but I think on this occasion the next one might be in public. So we'll obviously notify people of that. But otherwise, can I thank everyone for their attendance? And what I'll do is I'll close the meeting. But also I'll ask the people on the screen if you can just wait on for a moment or two whilst the recording closes. Thank you.